Chapter 2, we're going to talk about the regulation of blood flow and pressure. Okay, a very important principle in cardiovascular is the Fick principle of blood flow. We have two Ficks. We have a Fick's law of diffusion and we have Fick's principle of blood flow. Fick's principle can be used to calculate blood flow through an organ. And the equation is provided. The flow is equal to uptake divided by AV-O2 difference. This is uptake of oxygen divided by the AV-O2 difference. And this can be used to measure cardiac output. Required data that we have to have is oxygen consumption or oxygen uptake and the AV-O2 difference. AV-O2 difference means AV-O2 oxygen content, not PO2. So it's oxygen content, not PO2. And we can utilize this to determine blood flow across any organ bed. Okay, the Fick principle was originally devised as a way to measure cardiac output because we can determine a flow if I know an oxygen consumption and I know the AV-O2 difference. You can utilize the lungs and that determines cardiac output. But notice, we can rearrange the Fick equation to calculate an oxygen consumption. Oxygen consumption, whole body, is equal to cardiac output times the AV-O2 difference for the whole body. And again, that's C for content, small a for arterial, so that's arterial oxygen content. And the small v is for venous, again, C is for content, so that's total oxygen content venous side, which we would measure in the pulmonary artery. So by rearranging the equation, we can calculate an oxygen consumption for the entire body. Now, if I just replace cardiac output with flow, I can get the oxygen consumption for any organ of the body. Now, another way to talk about AV-O2 difference is just simply use the word extraction. When we apply it to the tissues of the body, we know venous oxygen is less than arterial oxygen, so that represents the extraction of oxygen. The AV-O2 difference, when applied to the organs of the body, represents extraction of oxygen. So, extraction and flow are two main players for total oxygen consumption. More specifically, extraction and cardiac output. All right, one of the things to remember is typically oxygen content is given in volume percent. So notice the very first part here. We have pulmonary venous, which is arterial blood, O2 content. Let's say it's 20 volume percent. It's pretty close to a normal arterial oxygen content. Remember, pulmonary veins have arterial blood. Well, volume percent means per 100 mil. So 20 volume percent means 20 mils of oxygen per 100 mil of blood. We could rewrite that and say that's 0.2 mils of oxygen per mil of blood. We may need to do that, and likely will have to do that, if we want to do a cardiac output calculation on step 1, which we will go through on the next slide. If you don't have data from pulmonary veins, which you typically will not, you'll just typically use an arterial O2 content. So from an ABG. You can substitute venous oxygen in place of pulmonary artery values, but then it will no longer quite be accurate. So most likely you will be given pulmonary artery volume percent and systemic arterial volume percent. And that systemic arterial will be from a peripheral blood vessel. All right, here's the application. So here's how we could calculate a cardiac output. Notice that we have pulmonary artery and pulmonary vein. We're going to say pulmonary artery, which has venous blood. Oxygen content is 15 volume percent. And again, we can rewrite that to say 0.15 mils of oxygen per mil of blood. Because notice that oxygen consumption in the lung is 250 mils of oxygen per minute. And so we need to get our units right. So we want to convert the 15 volume percent to 0.15 mils of oxygen per mil of blood. On the pulmonary venous side, where we have arterial blood, it's 20 volume percent. We're going to convert that to 0.2 mils of oxygen per mil of blood. Now we can calculate the flow, knowing that flow is oxygen consumption over the AVO2 difference. So in this example, oxygen consumption is 250. AVO2 difference will be 0.2 minus 0.15. When we plug and chug that, that will give us a flow of 5 liters per minute. Now notice, if you used 20 minus 15, you're going to be off by a factor of 100. And that's once again because volume percent means per 100 mil. So make sure you do the conversion when doing this calculation. Now the Fick principle can also be used without even doing a calculation. Now, I'm going to bring the Fick principle back in. And remember, we rearranged the original equation to say oxygen consumption equal to the flow times the AVO2 difference, oxygen extraction. So oxygen consumption is determined by the flow times the extraction. That's what the Fick principle tells us. Now, very big concept, high yield way to work with this information. Please remember that oxygen delivery is the front part of the Fick equation. Oxygen delivery is flow times content of oxygen. Again, oxygen delivery is flow times oxygen content. That's the front part of that Fick equation. This is delivery of oxygen to the capillary. Delivery of oxygen to the capillary. All right, to try to really drive this home, let's just use a very, very simple example. Let's say that our truck carrying oxygen, well, we know that's our red blood cell with hemoglobin. So that's a truck. It's carrying oxygen. And let's say each truck has 10 oxygens. Now, the flow is volume per unit time. So we have 10 trucks, let's just say, for example, 10 trucks per minute get to the capillary. So notice, delivery is 100 oxygen per minute. Again, oxygen delivery is flow times content. It's the amount of oxygen I have in the blood times the volume of blood arriving to the capillary per unit time, flow. That is delivery. And if you have to stop the video as we go through each of these stages to make sure you understand, please do so. This is a very, very powerful thing to work with, the Fick equation. So delivery is flow times content. In this example, let's say that the tissue takes 5 oxygens per truck. Well, then that means the tissue's taking 50 oxygen per minute, which leaves 5 oxygen per truck in the veins, so 50 oxygen per minute are leaving. Now go back up to the Fick equation. The flow is 10 trucks per minute. The AVO2 difference is 5. The tissue's taking up 5. Notice arterial is 10, venous is 5. So 10 times 5 is 50. So oxygen consumption is 50 oxygen per minute. Okay? So work with these numbers, make it nice and solid. Now, big application of this. For any given oxygen consumption, all right, so for any given oxygen consumption, if you reduce delivery, then the tissue is most likely going to get its ATP from just glycolysis, anaerobic glycolysis, which means lactic acid production. Well, that's acidosis, that's an acidemia, that's a lot of acid. Remember, tissues don't respond well to a lot of acids. And there's possibility of hypoxic ischemic damage. So this has a lot of implications for pathology. Remember, in pathology, you're going to look at tissue and think about tissue in which you have hypoxic ischemic damage. Well, that could be due to a reduction in oxygen delivery. The second application of this is that for any given oxygen consumption, if I decrease delivery, then it will decrease venous oxygen. All right, stop and soak that in for a second. For any given oxygen consumption, if I decrease delivery, I will decrease the amount of oxygen in the vein leaving that tissue. All right, how could that be? Well, let's reduce flow. Delivery is flow times content. Look over at the Fick equation, got an arrow down for the flow. Well, if flow goes down, then that means extraction had to go up in order to keep oxygen consumption constant. If flow goes down, the extraction has to go up in order to keep oxygen consumption constant. Well, if extraction goes up, then venous oxygen falls. If extraction's going up, then that means there's going to be less in the vein. All right, hopefully that makes good sense to you. All right, now, we said if flow goes down, then extraction goes up, and that's why venous oxygen goes down. But now, what happens if oxygen content goes down? Well, let's go back to our little simplistic example. Before, we had each truck had 10 oxygens. The flow was 10 trucks per minute, so we're delivering 100 oxygens per minute. Well, let's say that a truck now, instead of having 10, has 7 oxygen, which would mean oxygen content has gone down. So instead of having 10 oxygens, we have 7 oxygens. Well, that means delivery dropped from 100 oxygen per minute to 70 oxygen per minute. We're going to keep the flow the same. So we have 10 trucks per minute. Each truck has 7 oxygens. Well, if the tissue is taking 5 oxygens per truck, do you agree that trucks leaving now only have 2 oxygen per truck? So again, for any given oxygen consumption, if you reduce delivery, doesn't matter if you reduce delivery by reducing flow or reducing content, either way, if you reduce delivery, venous oxygen falls. This becomes a very, very powerful tool in analyzing problems on a clinical vignette. For example, if a patient, if their venous oxygen goes down, particularly if they're just lying in a bed, okay, lying on a gurney, say post-surgery, or they've just gotten to the hospital bed, maybe they're in ICU, and you're monitoring venous oxygen. Well, if venous oxygen falls, you know immediately oxygen delivery went down. Now what you have to do is figure out, is it a flow problem, or is it a content problem, or is it both? And there's various ways you can ascertain which it is. If it's a flow problem, you might look at blood pressure, see if blood pressure's down. Look at that pulse pressure. Did pulse pressure fall? If so, then stroke volume went down. Now we have to figure out why. Again, is it a heart problem or is it a volume problem? Those are the things that you're keying in on. If it's an oxygen content problem, then maybe you have an O2 sat, or maybe you do an arterial blood gas, do an ABG, and you're looking at PO2. If PO2 falls, then we know we have a content problem. Now we have to figure out, well, is it because they're not breathing enough? Or do we have some problem with diffusion across the lung, etc.? And hopefully, when you get through with all of these physiology lectures, you will be able to work with that very, very quickly. Again, notice we didn't even use a calculation. We're using the Fick principle, but we're not even making a calculation. Venous oxygen goes down, you know immediately delivery went down. Now we just have to figure out Which is it? A flow problem or a content problem? Or both? Very powerful application. Fick principle for physiology and for step 1. All right, now let's talk about blood flow regulation, more specifically, intrinsic regulation. We've already discussed the idea that blood flow is regulated by constricting and dilating, vasoconstricting, vasodilating, the arterioles, the smooth muscle of the arterioles. Now, what we're going to talk about now are control mechanisms, intrinsic, that are going to regulate arteriolar smooth muscle tone, and this will occur within the organ itself. Nerves are not involved, hormones are not involved. It is the tissue's way to regulate the faucet. If we think back to our whole body integration, our deep thoughts, we want to regulate those faucets. Well, this is the tissue's way to regulate the faucet. And again, that's regulated at arterioles. We have a term, third bullet point, intrinsic regulation, called autoregulation. The definition of autoregulation is the maintenance of a relatively constant flow despite changes in pressure. Again, the definition of autoregulation is the maintenance of a relatively constant flow despite changes in pressure. And we're going to have two mechanisms that are going to cause this intrinsic regulation, this autoregulation. These will be the metabolic mechanism and the myogenic mechanism. Okay, we will start first with the metabolic regulation of blood flow. Tissues will produce a variety of vasodilatory metabolites that regulate the flow. These include adenosine, carbon dioxide, hydrogen, and potassium. And remember, we derive adenosine from the breakdown of ATP. Bottom line, these are vasodilators. Okay, vasodilator metabolites. So the production of these dilate the arterioles. So we will get arteriolar dilation when the concentration of these metabolites increase. If the concentration goes down, then the arterioles constrict. So vasodilator metabolites relate to the metabolic mechanism of intrinsic regulation. A second mechanism is called the myogenic mechanism. And here, this is just a response of smooth muscle. When pressure goes up, it stretches the wall of the arteriole and the surrounding smooth muscle. The inherent property of the smooth muscle is to contract when stretched. So when the blood vessel stretches, in other words, pressure goes up, we get a stretch of the vascular wall. This causes contraction. When intravascular pressure goes down, then this smooth muscle will relax. So if the pressure is going up and the arteriole constricts, this will keep blood flow relatively constant. If pressure goes down and the blood vessel dilates, then this will keep blood flow relatively constant. Hence the mechanism or the term autoregulation. Now both myogenic and metabolic occur. And so it's really not important to try to say which one is more important. Bottom line is we should know both basic mechanisms. Okay, here's a graphical representation of autoregulation. Please note the axes. We have blood pressure on the X and flow on the Y. And notice what is called the autoregulatory range. So what this indicates is over this range of pressures, autoregulatory range, over this range of pressures, blood flow is held relatively constant. That's what autoregulation means. But it only works over a range of pressures. Notice on this graph that if pressure falls below 50, then blood flow is going to go down. So as pressure falls, blood flow falls. On the other end of the spectrum, around 150 or so, If blood pressure goes above this level, then blood flow goes up. Increase in pressure, increase in flow. Notice your relationship provided on the slide. Pressure, flow, resistance. See, we're still working with that basic idea. Now, over that autoregulatory range, what that says is that as pressure goes up, we're keeping flow relatively constant, so resistance had to go up in proportion. And both myogenic or metabolic can explain this. If pressure goes down, then we are decreasing resistance to keep blood flow relatively constant. And again, both myogenic and metabolic can explain this response. Now, if we go beyond the autoregulatory range, as we indicated, if blood pressure is too low, then clinically, here's your need for vasopressors like norepinephrine, dopamine, phenylephrine, etc. If blood pressure gets too high, then you may need a vasodilator, as indicated, like nicardipine, nitroprusside, hydralazine, etc. A lot of those drugs that we mentioned when we were discussing the idea of things that vasodilate and vasoconstrict peripheral arterioles. So again, autoregulation, it only works over a range of pressures, and it doesn't involve hormones, and it doesn't involve nerves. It's in the tissue itself. It's the tissue regulating the faucet, keeping its blood flow relatively constant, which means grocery delivery relatively constant. Remember, those tissues need those groceries. They need those groceries. Now, the autoregulatory range illustrated here, please remember this is a steady state response. It takes a few seconds for autoregulation to fully develop. So the graph that we're looking at is steady state, not instantaneous. All right, all tissues show some degree of autoregulation, but the big autoregulators are the first two, the brain and the heart. You know that the brain and the heart, they're the CEOs of the circulation. Yeah, they behave like CEOs. You know how CEOs behave. I want my flow, and I want it now. Now. Yeah, they're not going to tolerate any waste of time. Give me my flow. Give it to me now. Yeah, the brain and the heart, they're the CEOs of the circulation. They get very cranky very fast, and they make the entire body pay if they're not getting adequate flow. As you remember, the brain, when it's not getting adequate flow, what does it do? Turns off the lights. Nobody gets to play. We pass out. That's syncope. And if the heart's not getting this flow, it lets you know. Oh, crushing chest pain radiating down my left arm. Yeah, that's angina. So these two tissues really let you know. Now, skeletal muscle, when it's exercising, it becomes a CEO. It wants its flow, and it wants it now. All right, a very important aspect related to autoregulation will apply to the pathology of hypertension. In hypertension, patients' blood pressure is elevated above normal. So with this high blood pressure, their autoregulatory curve shifts to the new higher pressure. So somebody who has hypertension still has autoregulation, but this is occurring at much higher pressures than in the normal individual. And so the key point here is a number for blood pressure is not necessarily relevant. It depends upon the patient. For example, if you have a mean arterial pressure of 100, you're pretty much in the middle of the autoregulatory range in a normal person. However, notice in the hypertensive individual, you're well below the autoregulatory range, which means compromised blood flow to the brain or the heart and potentially to all the tissues of the body. But our CEOs are the ones that we're most concerned with. And that's why you have to be very careful in treating somebody with a high blood pressure if you don't know their history, like in surgery or in the ER. If somebody comes in the ER and they have a very high blood pressure, you don't necessarily bring it down to what is, quote, normal, because that could hurt the patient. So you're only going to bring it down a certain amount if you don't know the patient history. So this is a big, high-yield bridge to pathology, very important point in the clinics, and thus on step 1. So again, in a hypertensive individual, the autoregulatory range shifts. It shifts. All right, we had intrinsic regulation, which is about regulating the flow, okay, gatekeeper of flow. It's the tissue regulating the faucet. Extrinsic regulation is really more concerned with our second big function related to arterioles, and that is regulation of upstream pressure. If we recall, arterioles serve as the main site of resistance. So the key thing, there are two big key physiologic ramifications. Gatekeeper of flow, and so intrinsic is about the tissue trying to regulate its own flow. Extrinsic regulation is the other factor related to the consequence of arterioles being the main site of resistance, and that is regulation of upstream pressure. So extrinsic regulation, the big player here, and let's say that this could be skeletal muscle, this is resting skeletal muscle, we have sympathetic noradrenergic neurons. These are postganglionic sympathetics. They release norepinephrine, which causes alpha-mediated vasoconstriction. And much of what we discussed in that whole body regulation, cardiovascular regulation, was we talked about the idea of norepinephrine being a big player in a variety of vascular beds. This is extrinsic regulation. And of course we have angiotensin II, which can vasoconstrict. We also mentioned arginine vasopressin, which can vasoconstrict, and epi can vasoconstrict on the alpha receptor. Don't forget though, very, very high yield for step 1, big important point. Epi can also vasodilate by binding to the beta 2 receptor, GS cyclic AMP. So epi can cause vasodilation via beta 2 receptors. And it turns out that skeletal muscle has quite a few beta 2 receptors. So we can see significant increases in flow at a low dose epi via the beta 2 vascular receptor. All right, continuing on with the idea of resting versus exercising muscle. In resting muscle, it's sympathetic. This is norepinephrine alpha-mediated vasoconstriction. As we indicated also, exercising muscle becomes the CEO. It demands flow. So how are we going to increase that flow? Well, exercise is going to release metabolites. Okay, metabolites. So when skeletal muscle is exercising or working, there's a big increase in O2 consumption, which of course, think Fic, is going to cause a fall in venous oxygen. All right, the blood leaving that working muscle is going to have a low venous oxygen because we're going to increase extraction. So as I indicated, there's going to be a big increase in blood flow in exercising muscle, and it's the vasodilator metabolites. They are the big players here. Same ones we mentioned before, adenosine, CO2, hydrogen, potassium, all of these cause vasodilation. In addition, these metabolites will diminish norepinephrine's ability to vasoconstrict arterioles. You know that when we exercise, we turn on the sympathetic nervous system. It's a very important point, very important physiologic response in order to deal with this big stress of exercise. Exercise, dynamic exercise, running, walking, swimming, riding a bicycle, etc., is a big flow demand for the cardiovascular system, and that working muscle has to get an increase in flow in order for it to work. So one of the big players, vasodilator metabolites. And in that working muscle, norepinephrine will not be able to vasoconstrict very well. So that's why we can increase sympathetic outflow, which can decrease blood flow to other parts of the body, but it's not very effective in the working muscle, which hopefully makes sense to you because we have to deliver groceries to this new CEO. I want my blood flow and I want it now. Yes, now. The increase in shear stress with this high flow will also liberate nitric oxide, which will participate in the vasodilation. And last but not least is the muscle pump. This contracting and relaxing literally pumps blood through the working muscle. So these are our mechanisms for an increase in flow: vasodilator metabolites, more nitric oxide, and the muscle pump. All right, now let's just talk about some specific vascular beds. We'll start first with the heart, particularly the left side of the heart. A couple of things going to increase coronary blood flow. On a beat-to-beat basis will be mechanical effects, mechanical compression. And that's what's illustrated on this slide. To the left coronary, which is providing most of the blood flow for the left ventricle, you have to remember that left ventricle, when it contracts, will compress the vasculature, particularly the subendocardial vessels. So what this means is you get very little, if any, blood flow during systole. That mechanical force is compressing the vasculature and can stop blood flow, which then means, which should follow, that most of the blood flow is going to occur during diastole. Okay? Now, there is some subepicardial flow during systole, but that subendocardial flow, as I indicated, could go to 0. And so we're going to get our blood flow to the left ventricle during diastole. Now, the big point that relates to this is, well, what's the pressure head driving flow to the left coronary artery? It's no longer so much mean arterial pressure as it is diastolic blood pressure, because we're getting most of the flow during diastole. Then it's going to be diastolic pressure that is the pressure head driving flow to the left ventricle, to the coronaries of the left ventricle. And that's why an adequate diastolic pressure is so important. Moving to the right side, the characteristics of right coronary blood flow. There will be ventricular contraction. Right side contracts just like the left, but this will only cause a modest mechanical compression. Nothing compared to the left ventricle. Remember, right ventricular wall is not nearly as thick as the left. We're not even close to the same levels of pressure being generated. So we still get a significant flow during systole. That diastolic pressure is still important even on the right side. Okay, so we still get the greatest flow during diastole, but the key point is that mechanical compression that we saw on the left side that is not nearly as robust on the right side. All right, the other big player for regulating coronary blood flow, and you should just tie these two together, will be oxygen consumption. And one of the unique properties of the coronary circulation is it extracts almost all the oxygen that can be extracted even under basal conditions. So in other words, venous PO2 is extremely low. So we are near maximum oxygen extraction under resting conditions, which is different than the other tissues. So we think Fick, the Fick principle that we discussed earlier in this chapter. The only way we can deal with an increased oxygen demand is to increase flow, because we can't get really any more extraction. We're close to maximal at rest. Well, remember, the heart never truly rests, so it's kind of unfair. But the key point is we're extracting almost all the oxygen that we can, even at rest. So coronary blood flow is tied to oxygen consumption of the heart. It must match metabolism. The flow must match metabolism. So Coronary blood flow is just tied to cardiac tissue oxygen consumption. Okay? The greater the oxygen consumption, or in other words, the greater the oxygen demand, the greater the coronary blood flow. Just put them together. You just can't separate them. What drives coronary blood flow? Oxygen consumption of the heart. Put them together. You can't separate them. Mashed potatoes and gravy, peanut butter and jelly, beans and rice. They just go together. You can't separate them. Just that is a key thing to remember. It is oxygen consumption of the heart. That's what drives coronary blood flow. Since coronary blood flow is being driven by oxygen consumption of the heart, all right, coronary blood flow is determined by the pumping action. Well, let's think about what influences oxygen consumption. Well, it's stroke work times heart rate. Stroke work times heart rate. And stroke work means pressurization and ejection. What does the heart do in systole? Pressurizes and ejects. Pressurizes and ejects. So, increasing the pumping action means increased metabolism. More metabolites, increase coronary blood flow. Again, they're tied together. Oxygen consumption, coronary blood flow. Don't try to separate them. So, what's going to increase oxygen consumption of the heart? Well, same parameters that affect cardiac output. These are heart rate and tip your cap to the ventricle for keeping you alive. Contractility, afterload, and preload. Contractility, afterload, and preload. So these four parameters determine oxygen consumption of the heart and thus determine coronary blood flow. Now, one of the aspects to appreciate for step one is heart rate, contractility, and afterload costs more metabolically than preload. So heart rate, contractility, and afterload cost more metabolically than changes in preload. And we sometimes say this afterload work is pressure work and the preload is volume work. So you may hear those terms, pressure work and volume work. Pressure work would relate to afterload and volume work relates to preload. All right, some applications. Conditions in which heart rate, contractility, and our afterload are increased. Well, hypertension, that is a big one. That is a big one. Aortic stenosis is another one. A stenotic valve is a resistor. That's a big increase in afterload. And exercise. Contractility goes up, heart rate goes up. In exercise, that requires a big increase in flow compared to conditions that only increase preload. Conditions like going to the supine position, aortic regurg, or some type of volume loading. Yes, exercise does increase preload as well, but it also increases heart rate and contractility. So big demand on the heart. Okay, that was the heart. Now let's talk about the brain. The brain is a great autoregulator, but there is one circulating factor that's going to influence the cerebral circulation, and that is arterial PCO2. Arterial PCO2, which is regulated by what organ system? I hope you said lungs. Absolutely, the lungs. If we hypoventilate, then CO2 goes up, and this tends to increase cerebral blood flow. In contrast, when we hyperventilate, this drives CO2 down and can decrease cerebral blood flow. Think about somebody who hyperventilates. So they start hyperventilating. Yes, you haven't breathed in a bag, but if they're hyperventilating, can they pass out? Absolutely, and part of that reason is the drop in PCO2 causing cerebral vasoconstriction. We turn out the lights and we get a syncope event. So even though the brain is a great autoregulator, PCO2 is a very important player. And if we think about this, this comes into application when we have head trauma. So imagine a clinical vignette on step one, or even in real life, we have somebody who has had a head trauma and we need to reduce cerebral blood flow. One of the ways to reduce cerebral blood flow is to have them hyperventilate. Arterial PO2 can influence cerebral blood flow, but it's not nearly as big a player as arterial PCO2. So if PO2 is normal or above normal, then it's all going to be related to the CO2. For example, if a normal person switches from breathing room air to 100% oxygen, you're really not going to affect cerebral blood flow. On the other hand, if you get a large decrease in arterial PO2, this can markedly increase cerebral blood flow independent of the CO2. So a large drop in PO2 can cause marked cerebral vasodilation and a big increase in cerebral blood flow. Example, high altitude. That's a beautiful example. High altitude, you have a low arterial PO2, and that can drive a big increase in cerebral blood flow in addition to the pulmonary edema. Okay? And so a large drop in arterial PO2 has a big impact, and you'll increase cerebral blood flow. The baroreceptors and sympathetics do not affect the flow in any significant way. It is PCO2 number one, and then a large drop in PO2. All right, a large drop in PO2, which again can occur in high altitude or high altitude pulmonary edema. Even without the pulmonary edema, you can still see an increase in cerebral blood flow due to the low arterial PO2. For the cutaneous circulation, this one's going to be primarily controlled by sympathetic adrenergic nerves. Again, adrenergic means releasing norepinephrine to cause alpha-mediated vasoconstriction. You have a lot of venous aspects related to the cutaneous circulation, so it can be a big volume storage. We have these large venous plexi. These are innervated by sympathetics. Again, alpha-mediated vasoconstriction. We have AV shunts, arterial venous anastomoses, that are innervated by sympathetics. Now, the blood flow to the skin is, of course, for nutrition, but it also plays another huge role. And cutaneous blood flow plays a huge role in thermoregulation. And so the sympathetic regulation of this vasculature is going to be primarily involved with thermoregulation. All right, so the sympathetic stimulation to the skin, what's it going to cause? Well, constriction, alpha-mediated vasoconstriction, because remember, this is postganglionic sympathetic norepinephrine. Now, they have a lot of alpha receptors there, and this is why you oftentimes have to administer or use a central line to infuse vasopressors, so that, you know, if you had a peripheral line and you're constricting those veins down because of that vasopressor with all of those alpha receptors, then it can cause a distal necrosis. We can reduce the blood volume in the skin, as I indicated before. We can have a lot of venous storage here, so the venoconstriction will mobilize blood away from the skin. And the big player is thermoregulation. We are going to vasodilate to dissipate heat. We're going to vasoconstrict to conserve heat. Now you may be asking, well, how are you going to vasodilate? Well, heat will directly vasodilate, but if core body temperature is tending to go up, we're going to vasodilate by inhibiting sympathetic outflow, because sympathetics are the main players. All right, this is a very nice slide to summarize the idea of control of cutaneous circulation, and we put it in a clinical context, and that is fever. All right, we have sensors in the anterior hypothalamus that are going to monitor blood temperature. We need to keep blood temperature, body temperature, relatively constant, around 37 degrees C. That's our set point for body temperature. Now, fever, oftentimes people think, well, you've lost the ability to regulate body temperature. That's not true. What has happened in fever is we've simply changed the set point. So the hypothalamus set point has been changed. So it's like taking your thermostat and increasing it from 37 to 39. Now, doing that, you know that your house or apartment's going to warm up. Well, exact same thing for the body. So fever is a change in set point. And what's thought to be the big player causing this change in set point is prostaglandin E2. So prostaglandin E2 causes the set point, the thermostat of your body, to be raised from 37 to 39. So what are you going to do? You're going to engage mechanism to increase body temperature. It's like turning on your heater in your house. Well, the mechanisms for increasing body temperature are skin vasoconstriction. Again, we said we decrease blood flow to the skin to conserve heat, and you will also shiver. Shiver is that oscillation of muscle contraction, which is not very good for moving things, but when that muscle contracts, it generates heat. I mean, stop and think about it. Have you ever said to somebody, or someone said to you, "My, you look pale today. Are you not feeling well?" Well, that pale of the skin is vasoconstriction of the skin. No, you're not feeling well. And they reach over and touch you. Yeah, you're warm. Yeah, your body temperature has gone up. And that's because the set point has been changed. Now, when the fever breaks, then that means the set point is returned back to the normal level. So it's gone from 39 down to 37. So what are we going to do? Engage mechanisms to drive body temperature down. It's like turning off your heater or turning on your AC. Well, for the body, what do? We vasodilate the skin. So an increase in skin blood flow is for dissipating heat. And we can also sweat. And the evaporation of sweat is a cooling mechanism. So very high yield slide here. Regulation of body temperature involving the skin, but also mechanisms for increasing heat like shivering or decreasing body temperature like sweating. And again, prostaglandin E2 is thought to be a big player. That's why you give non-steroidal anti-inflammatory drugs to reduce a fever. Block that cyclooxygenase, block the production of PGE2. Okay, just a couple of 3 quick facts related to the renal and splanchnic. They're both good autoregulators. You know, tissue wants to regulate its own flow, so if we get small changes in blood pressure, renal, gut can autoregulate, maintain their flow. Okay, so they both are good autoregulators. However, they're also under influence of the sympathetics, and in times of stress, when we get a large increase in sympathetic activity, you will vasoconstrict the skin and vasoconstrict the kidney or the renal circulation. Now the kidney, it's overperfused. If you think about it, in terms of its nutrient requirements, it's overperfused. How do we know that? Venous PO2 is high. Think FIC. Flow times extraction. Oxygen consumption is flow times extraction. You have a very high venous PO2, it's telling us, well, you're not extracting a lot of oxygen, so you must be getting a lot of delivery. You must be getting a lot of flow. And that's true. And that makes good sense because remember, the renal circulation isn't just about giving nutrients, okay, delivering groceries to the kidney. The kidney filters the blood, so it needs a lot of blood flow. 20-25% of the cardiac output goes to the kidney, as does about 25% go to the splanchnic circulation. That's why in times of stress, we're going to reduce renal blood flow, we're going to reduce gut blood flow. There's a lot of blood there, needs to be mobilized, need to maintain that blood pressure, keep the heart and the brain, the 2 CEOs, nice and happy. Now, when do we see a big increase in splanchnic blood flow? Well, that's when we digest a meal. There'll be a lot of mechanisms for that. Metabolic being a big player, but also some hormones will be involved. But you get a big increase in splenic blood flow when you digest the meal. Rest and digest. So don't go for a run. Don't go swimming. Like Mama said, don't go swimming after you eat. Yeah, that's true, because you don't want that CEO exercising muscle and the gut competing for blood flow. Sometimes that doesn't work out very well, does it? Okay, when you think pulmonary circulation, the first thing I want you to think in your mind is veins. All right, the pulmonary vasculature, even the arterial side of the pulmonary vasculature, is structurally more like veins. So it's going to behave like veins. It's a low pressure circuit. Notice we have a small pressure drop. That means a low resistance. That means a low resistance. You get the entire cardiac output goes to the lungs. So the pulmonary circulation receives the entire cardiac output. And that blood flow has one job and one job only. Pick up groceries, dump off trash. Pick up the oxygen, dump off that CO2. So huge amount of blood flow. Huge amount of blood flow. The vessels are like veins, very compliant. Remember, very compliant. So the first thing that should pop in your head when you're thinking about the pulmonary circulation is veins. Think veins. All right, there is one aspect that's very important with respect to the pulmonary circulation, and this is hypoxic vasoconstriction. If alveolar PO2 becomes low, so a low alveolar PO2, this will cause a local arteriolar vasoconstriction. This is referred to as hypoxic vasoconstriction. So low alveolar PO2 vasoconstricts. Now, the blood volume that's in the pulmonary circulation, think veins, is proportional to the blood flow. All right? We have a very compliant pulmonary circulation, and so large changes in the output of the right ventricle usually only cause small changes in pulmonary pressure because it acts like veins. Veins can distend and veins can recoil back. Let's look at a couple of examples related to that. Exercise. Beautiful example to work with the pulmonary circulation. Exercise. We've got a big increase in cardiac output. Well, that means a big increase in the volume of blood pumped into the pulmonary circulation. The entire cardiac output goes there. This, if nothing changed resistance-wise, would cause large increases in intravascular pressures in the pulmonary circulation. Cardiac output can go up 3, 4, 5-fold. Some of these elite endurance athletes, they've shown cardiac output increasing 8-fold. It's a huge increase in output. But because we have a very compliant circulation, that vasculature will distend in response to this big increase in flow. And if it's distending, then radius is getting bigger, so resistance is falling. In addition to distension, reducing resistance, we also have what's called recruitment. Now you have to remember, you have millions and millions of alveoli. And these are surrounded by billions and billions of capillaries. That's a lot. Some of these capillaries aren't being perfused at rest. And so as pulmonary blood flow goes up, we start recruiting these unperfused capillaries. So we are distending and recruiting, which means pulmonary vascular resistance is going down as we have this big increase in cardiac output. Consequence of that, there's only a slight rise in pulmonary artery pressure during a high cardiac output state, exercise being the classic example. Now, if we didn't have this recruitment and distension, then think about it. Cardiac output goes up 5-fold, then pulmonary artery pressure would go up 5-fold. And we don't want a pulmonary artery pressure like that. And these elite endurance athletes, as I indicated, eightfold, we certainly can handle an eightfold increase in pulmonary artery pressure. Yeah, that's pulmonary edema. That's pulmonary edema. So, very beneficial recruitment and distension, reduce pulmonary vascular resistance. So, pulmonary artery pressure doesn't go up as much as one would predict, not nearly as much as one would predict when we have a high cardiac output state. And again, exercise, the classic example of a high cardiac output state. All right, going the opposite direction to exercise is hemorrhage. Here we're going to have a large decrease in cardiac output. Because we decrease cardiac output, intravascular pressure in the pulmonary circulation would go down. But veins, remember, even though they're very compliant, they're compliant rubber bands, they will snap back. They have some degree of elasticity. So these pulmonary vessels will recoil, which means they won't store a lot of blood. In addition, we have a de-recruitment of pulmonary capillaries. Both of these cause a rise in pulmonary vascular resistance. So when cardiac output's falling, in hemorrhage, for example, this recoil property is going to help raise pulmonary vascular resistance. This de-recruitment will raise pulmonary vascular resistance, but also this recoil property means I'm not going to store a lot of blood. Remember, veins can store a lot of blood, and we don't want that happening in hemorrhage. So, as a consequence of the rise in pulmonary vascular resistance, pulmonary artery pressure doesn't just fall off the table. It doesn't fall so low during hemorrhage. Now, why is that important? Because pulmonary artery pressure is the pressure head driving flow through the pulmonary circulation. If I have an inadequate pulmonary artery pressure, I won't be able to drive flow through the pulmonary circulation. So veins, think veins. Veins and this recruitment, de-recruitment, big players in pulmonary circulation. Okay, let's talk a little bit about the fetal circulation for step 1. The numbers on here that are bolded will represent the hemoglobin saturation. All right, first fact to remember for fetal circulation is about 55% of the fetal cardiac output goes to the placenta. 55, that's more than half of the cardiac output goes to the placenta. And that makes good sense because the placenta is the grocery store, right? That's where we pick up substrates, that's where we pick up oxygen, that's where we dump off CO2 because the lungs aren't working in a fetus. So it should make good sense that the umbilical vein, which is coming from the placenta, has the highest O2 sat, but it's only about 80% saturated. But nonetheless, that's where we're going to have the highest O2 saturation because the placenta is the grocery store. Now, this blood will then go in to the inferior vena cava. Some of it goes to the liver, but much of it bypasses through the ductus venosus, and will mix in with the venous blood draining the lower portions of the fetus. So by the time we approach the heart, we've dropped that saturation because we're mixing in that venous blood. It's dropped down to about 67%. Now, most of this blood will go into the right atrium and then directly into the left atrium via the foramen ovale. From there, the left atrium goes to the left ventricle, which gets pumped into the aorta. Now, the blood being drained from the superior parts of the body, from the head, get drained by the superior vena cava. And notice that we only have about 40% saturation. Most of this blood flow goes to the right atrium, then to the right ventricle, and pumped into the pulmonary artery. Now, the lungs are collapsed, so the pulmonary vasculature has a very high resistance. Therefore, most of this blood gets diverted from the pulmonary artery into the aorta via the ductus arteriosus. So now this blood's going to mix in with our other blood, and by the time we get around to the aorta, go into the tissues, you're only about 60% saturated. all right, which is considerably lower than in an adult. Now let's remind ourselves about fetal hemoglobin. Fetal hemoglobin has a much higher affinity than adult hemoglobin. The idea is the placenta is good. I mean, I'm not going to knock the placenta. Placenta does a great job, but it's not the lungs, not for moving gas. The lungs were made to move some gas. Man, do they move some gas. Placenta does a fine job, but nothing in comparison to the lungs. So the idea is, well, the grocery store is not going to have tons of oxygen. So what are we going to have to do? We're going to have to snatch onto it and hold onto it tight. So very high affinity fetal hemoglobin. Now the downside is it doesn't want to give it up. If we have high affinity, then it doesn't want to release the oxygen at the tissue. But it works okay for that fetus who's just kind of lounging in that swimming pool. It's not a big deal, not a big oxygen consumption there. So it works out okay for the fetus. And those are important points to think about for step 1. Now at birth, we're going to lose that circulation to the placenta. That's 55% of the cardiac output. We have a big increase in resistance. All right, what happens to upstream pressure when I increase resistance? Hopefully you said increase. You got it. And so upstream pressure goes up. That's the aorta. So that higher pressure means higher pressure to the left ventricle, left atrium. That helps close the foramen ovale. The lungs now inflate. So their resistance goes way down. Pulmonary vascular resistance goes way down with that first breath. And that helps. We have a difference in the pressure gradient. So that's going to drive that blood flow in the pulmonary artery to the lungs rather than to that high pressure aorta, and that helps close the ductus arteriosus. All right, so those are the basic elements to think about fetal circulation wise for USMLE step 1. Now let's add a quick little pathology here while we're right here. Let's think about an atrial septal defect or a ventricular septal defect or a patent ductus arteriosus. Let's put those 3 together and, kind of group them together. Now you may ask, why you group these 3 together? Because the big key is those will not produce cyanosis. Those will not produce cyanosis. A patent ductus arteriosus, an open or patent foramen ovale, which we call an atrial septal defect, or a ventricular septal defect are all what we call left to right shunts. So it's arterial blood mixing in with venous blood. So the blood is going from the left side of the circulation back to the right. All of these are going to be associated with a markedly elevated pulmonary blood flow because we're moving it from the left to the right side. So pulmonary blood flow will go up. This can be a stress on the right ventricle. You may even get some hypertrophy. And pulmonary artery PO2, which is normally low, venous PO2, is going to go up. It's going to go up in all of those conditions because they're left to right shunts. Contrast that with tetralogy of Fallot, in which we have right ventricular hypertrophy with a VSD, and that creates a right to left shunt, and that causes cyanosis. So review a little bit the idea of those pathologies, those big yield, high yield pathologies related to the fetal circulation. All right, the last part of this chapter is going to deal with some things that we need to think about for exercise. We've actually discussed the pulmonary circuit and exercise. There's only one thing I want to highlight here, and that's what's shown in gray in the gray box. Is because we're recruiting previously unperfused capillaries, we will increase capillary surface area. So there is an increased rate of gas exchange with exercise. We'll continue on with a few more important high yield aspects related to exercise. All right, some things to think about and know for step 1 related to exercise. The arterial system. In general, PO2 is fine. Hemoglobin is fully saturated. PCO2 is usually fine, doesn't usually change a lot. which means that the increase in ventilation is proportional to the increase in metabolism. You might see CO2 starting to sneak down as you start to go to higher and higher levels, but it's not going to go up. If anything, it's going to go down, and there is a tendency for it to go down as you approach max. But what this says is we're maintaining PO2 and PCO2, so the lungs are doing their job in exercise. The lungs are doing their job. pH is pretty much stable until you hit that, everybody knows, lactate threshold. Then if you keep working and increasing intensity above that level, more and more lactic acid comes out. And you can actually get a lot of lactic acid in the blood during exercise. Mean arterial pressure, there is a slight increase. Now let's think about this. If mean arterial pressure is going up just a little, but cardiac output's going up 5-fold, so if I get a 5-fold increase in cardiac output and a slight rise in mean arterial pressure, that means TPR is really falling. Body temperature is going to go up, as we would predict, because we're generating heat. Can you tell me what's going to happen to cutaneous blood flow? If you said increase, you got it, to dissipate heat. So as we indicated, that vascular resistance is going to fall way down. And why does that resistance fall? That's because of that vasodilation in skeletal muscle. And again, those were vasodilator, metabolites in skeletal muscle, liberation of nitric oxide, and the muscle pump. As we would predict from the Fick equation, venous PO2 is going to go down. Remember, oxygen consumption went up, so what's going to happen in skeletal muscle? Flow is going to go up, extraction of oxygen is going to go up. That means venous PO2 will fall. As we would also predict, PCO2 is going to go up because we're generating more CO2 as a result of metabolism. So venous CO2 will go up. Not arterial, but venous. Lungs do their job. All right, we should be able to think our way through various aspects here. Exercising skeletal muscle, vascular resistance falls. That means blood flow goes up. It just follows. We just apply. We know if resistance goes down, blood flow goes up. And if blood flow goes up, capillary pressure goes up. And if capillary pressure goes up, then we're going to filter more. So we're going to see an increase in lymph flow, as we would predict. All we had to remember was vasodilator metabolites, NO, muscle pump, vascular resistance, and skeletal muscle falls. All the rest we could predict. We're not trying to memorize these. We just work with our information. We can predict all of these. So we're not trying to memorize everything. We just work with our knowledge. As I indicated on the previous slide, O2 extraction is going to go up, so venous PO2 falls. It just falls into place when we have a good, solid core of understanding basic principles. All right, you already told me what's going to happen to cutaneous blood flow. Yep, it's going to go up. It's going to go up. We've already talked about what happens at the heart. Heart rate goes up, preload goes up, contractility goes up. So what's going to happen to oxygen consumption of the heart? It's going to go up. So we know coronary blood flow is going to go up. We know that because the work of the heart goes up. Since we're maintaining CO2, what do we think? Cerebral blood flow? Yeah, should be pretty much the same. CO2 is okay. Mean arterial pressure is okay. So cerebral blood flow, by and large, no big change. No big change. Kidney, gut, vasoconstrict. And the greater and greater the workload, the closer and closer you get to max, the more and more you're going to vasoconstrict. We have to have that blood flow for the rest of the body. As we talked about, big vascular beds, huge percent of the cardiac output goes to these two vascular beds. We're going to have to divert it away from there. Sympathetic, it's going to vasoconstrict in these vascular beds. All right, some things they may ask you about regarding physical conditioning on USMLE Step 1. Exercise is becoming more and more important in the idea of clinical medicine. One of the things that regular exercise can do is increase your maximum oxygen consumption, sometimes called VO2 max. Now we increase VO2 max because we increase our ability to deliver oxygen to active muscle. Now let's remind ourselves, delivery is, are you saying flow times content? Flow times content. I certainly hope so. So we're going to increase the ability to deliver flow. Now, in a resting state, for a person, in the resting state, they're going to have a lower heart rate, but they'll have a greater stroke volume, more flow, a greater stroke volume. So at any level of exercise, stroke volume is increased. One of the big changes, physical condition-wise, is the strength of the heart and the ability of the heart to pump out blood. Maximal heart rate is unchanged. So you can train all you want and it's not going to change your maximal heart rate. But we can deliver more oxygen because we can get a greater flow. And that greater flow is a greater stroke volume. It's a greater stroke volume. Skeletal muscle will also change. Cardiac muscle changes. You get stronger, more forceful contraction. We can increase that stroke volume and thus increase the flow and delivery of oxygen. But skeletal muscle will also change. We'll get an increased number of arterioles, which can help lower resistance during exercise. There's an increased capillary density that increases the surface area and decreases the diffusion distance. So we get, bottom line, angiogenesis in skeletal muscle, which enhances our ability to utilize oxygen. That's part of what training does. And you will also get an increase in the number or concentration of oxidative enzymes in the mitochondria. So the heart can contract and eject more blood. That's a big change with physical conditioning. But also skeletal muscle will change. More arterioles, greater capillary density, and more oxidative enzymes. All of these are the big changes to think about related to aerobic physical conditioning for step 1.